Hello everyone, I am Dr. Syeed Mehbub Kadir. Now I am going to talk on orbital cellulitis. I have no financial interest to disclose in relation to this presentation. The most common cause of orbital cellulitis of orbital infective disorder is bacterial infection. Others include fungal orbital infection and parasitic orbital infection. Orbital cellulitis can be caused by an extension from the infection of the periorbital structures like rhinosinusitis, dacrocystitis, periorbital skin infection, infection of the teeth, medullary infection, upper respiratory tract infection, ocular infection like endophthalmitis, and orbital trauma with fracture and foreign body can cause orbital infection and orbital abscess. Its causes can also be exogenous or endogenous. Children younger than 9 years of age, infections resulting from sinusitis are usually due to one aerobic bacterium, typically Staphylococcus and Streptococcus species. Patients older than 9 years of age and in adults with orbital cellulitis more often exhibit polymicrobial profile with both aerobic and anaerobic bacteria. Patients with sinusitis is commonly infected from anaerobes and gram-positive organisms. Modern management modalities have reduced the rate of visual loss, functional deficit, and mortality. The Chandler classification describes 5 categories of orbital infection, but not necessarily found in the chronological order. Group 1 is periceptal cellulitis, Group 2 is orbital cellulitis, Group 3 is superficial abscess is present and surgical intervention is often required. Group 4 is characterized by an orbital abscess, and Group 5 includes a cavernous sinus thrombosis. Periceptal cellulitis occurs anterior to orbital septum. Eyelid edema, erythema, and inflammation may be severe, but the globe is uninvolved. Therefore, pupillary reaction, vision, and ocular motility are not disturbed. Pain on eye movement and chemosis are absent. Orbital cellulitis involves structures posterior to the orbital septum. Clinical findings include fever, erythema, proptosis, ptosis, restricted ocular motility, and pain with ocular movement. Complete blood count showed leukocytosis, decreased vision, impaired color vision, restricted visual fields, and pupillary abnormalities suggest optic neuropathy that demands immediate and aggressive management. Adults are less likely than children to have orbital abscess. Abscess formation may be suggested by progressive proptosis, globe displacement, or failure to show clinical improvement despite appropriate antibiotic therapy. Abscess is usually localized in the superficial space adjacent to the infected sinus. Regarding superficial abscess location, 53% reported medial, 23% as superior, and 23% as supromedial. Adults are less likely than children to have orbital abscess. Clinical features comprises raised malaise and fever, increased proptosis, increased periorbital inflammatory signs, ophthalmoplegia, decreased vision, disc edema, and palpable fluctuant mass. The most common cause of orbital abscess is orbital trauma with vegetative foreign body. Cavernous sinus thrombosis is often heralded by the rapid progression of proptosis, the development of ophthalmoplegia, and the onset of anesthesia of first and second division of trigeminal nerve. Meningitis and frank vein abscess may develop. Children with orbital cellulitis are usually showing different clinical picture than adults. In children, accompanied by acute onset and rapid progression of eyelid swelling. More frequent systemic features include malaise, fever, anorexia associated with pansinusitis. In adults, most frequent feature is proptosis, and drainage is often necessary to prevent complications. Workup for orbital infective disorder, especially bacterial infection. All cases with suspected orbital infectious disorders require a clinical history and thorough physical examination. Imaging studies are imperative, and a CT scan of the orbit is the method of choice to remove the paranasal sinuses for sinusitis and to differentiate the orbital cellulitis from subrostial and orbital abscess. Lumbar puncture should be performed if clinical pictures suggest cavernous sinus thrombosis, meningitis, and brain abscess. Empiric antibiotic therapy should correspond to the presumed etiology of the infection. In children 9 years of age or younger require monotherapy with cefuroxime or ceftriaxone alone. Part in older children and adults, clindamycin or metronidazole may be added to cefuroxime or ceftriaxone for anaerobic coverage. Gram-negative coverage should also be included in all patients with trauma-associated orbital cellulitis, with no evidence to determine whether intravenous antibiotics are better than oral antibiotics in the management of simple preceptor cellulitis in the pediatric population. Systemic steroids can be used as adjunct therapy in combination with intravenous antibiotics or oral antibiotics 48 to 72 hours, especially in the pediatric orbital cellulitis or subperiosteal abscess cases, for faster resolution of inflammation and minimizing functional deficit. Criteria for surgical drainage includes patients older than 9 years of age, presence of orbital sinusitis, non-medial subperiosteal abscess, large subperiosteal abscess, it may be medial or non-medial, anaerobic infection, recurrence of abscess, evidence of chronic sinusitis, and abscess is associated with acute optic neuropathy or compromised retina. The timing of surgical drainage of abscess differs depending on the patient's presentation. It can be categorized as emergent drainage or urgent drainage. Emergent drainage is indicated for impaired optic nerve function or compromised retinal function, fever persists more than 36 hours, or fevers decline on 48 hours of initiating antibiotic therapy, and abscess associated with intracranial complications like urgent drainage is indicated for large subperiosteal abscess or non-medial subperiosteal abscess, abscess associated with frontal sinusitis or chronic sinusitis, and patients older than 9 years of age. The aim of surgery is to decompress optic nerve and to obtain material for identification of organism and antibiotic sensitivity. Many patients will not need sinus surgery at the time of the subperiosteal abscess drainage. However, if needed, the orbit and sinus can usually be drained simultaneously. Medial subperiosteal abscess can often be drained endoscopically. The surgical approach depends on its location, the preference, and training of the surgeon. Approaches include CT image guided aspiration, transcutaneous or transconjunctival orbital approach, endoscopic endonasal approach for medial subperiosteal abscess. This video is showing a transcutaneous image guided aspiration with a candidate needle in can be done endoscopic approach. It is easy procedure. Need endoscopic. Now, fungal orbital infections are not common and usually occur as opportunistic infection. The most common fungal orbital infections are mucormycosis and aspergillosis. Both are mimics, others orbital infections, inflammations, and malignancy. Orbital fungal infections are not only vision threatening but also associated with high mortality. The initial site of infection of rhino-orbital cerebral mucormycosis is the nasal turbinate. An acute episode of sinusitis progresses into pansinusitis within a few days with contiguous spread to the palate, orbit, and brain, resulting in severe tissue ischemia and necrosis due to the angioinvasive nature of the fungus. The mucormycosis occurs almost exclusively in immunocompromised hosts. Approximately 60 to 80% of cases occur in uncontrolled diabetic patients with ketoacidosis. In COVID data, COVID patients, those who received steroids and treated with immunomodulators like tocilizumab and received oxygen therapy for a long time and stayed in ICU with ventilation, all are vulnerable for developing mucormycosis. Other risk factors include cancer patients treated with adjuvant therapy, organ transplant and hematologic malignancy, intravenous drug addict, and history of recent trauma. Early signs and symptoms of mucormycosis include fever, sinusitis, nasal discharge, epistaxis, orbital and periorbital pain, nasal mucosal ulceration, crusting, and necrosis. A black abscess over skin, nasal mucosa or palate is characteristic of mucormycosis but is a late and inconsistent finding. Decreased vision, corptosis, periorbital edema, and complete external ophthalmoplegia are the most common ophthalmic features. From the orbit, the infection can spread to brain through cribriform plate and orbital apex. Invasion of the cavernous sinus and cavernous part of the carotid artery can lead to carotid occlusion, cerebral infraction, intracranial aneurysm or hemorrhage, fungal meningitis, mycotic abscess, and eventually cause death. Aspergillosis is an uncommon infection of the orbit that can affect both immunocompromised and healthy immunocompetent hosts. Orbital involvement is common in invasive aspergillosis. Nasal and oral mucosa should be thoroughly examined in a suspected case. Suspected patients should undergo appropriate radioimaging study like MRI or CT scan of paranasal sinuses with brain contrast study of mucormycosis. Plain CT scan of the thorax is indicated for pulmonary mucormycosis. CT and MRI can also help to delineate the extent of infection and can guide surgical debridement. Biopsy of the involved tissue or paranasal sinus secretion are diagnostic. For mucormycosis, one portion of the biopsy tissue should be kept in sterile saline for microscopy and culture, and other portion should be kept in formalin saline for histopathology. Evidence of angioinvasion and tissue infection may also be observed. Mucormycosis is an aggravating infection with high mortality rate. It should be treated as an emergency without any delay in initiation of therapy. The management strategy include surgical excision of necrotic tissue or debulking of the necrotic tissue to reduce the fungal burden, exenteration, and medical treatment, and both medical and surgical treatment. This video showing endoscopic endonasal approach to reduce the burden of fungal tissue from the sinoorbital area. Apoptosin B, like lipid formulation or liposomal apoptosin B, is helpful for the management of mucormycosis or aspergillosis. The intravenous voriconazole are using as the first line treatment for invasive aspergillosis. Oral voriconazole can be instituted after completion of parenteral amphotericin B or can be considered as an alternate therapy in patients who cannot tolerate amphotericin B. Parasitic orbital infections include orbital cysticercosis and echinococcosis, known as hydatid cyst. Orbital cysticercosis usually involve the extraocular muscles. It may present as orbital cellulitis like symptoms. CT scan of the orbit is usually showing a characteristic cystic lesion and a hyperdense spot within it known as scolex. Oral albendazole is the treatment of choice. Excision of the cyst is often required. Now, echinococcosis, known as hydatid cyst, it present as periorbital pain and proptosis due to large cystic lesion. CT scan of the orbit show a well encapsulated cystic mass. Surgery is the mainstay of treatment. We should keep in mind for masquerades. Now take a message. Orbital infective disorders in large spectrum and variable clinical course. So clinical evaluation, imaging technique, histopathological analysis and microbiological examinations all are help in diagnosis. Fungal etiology must be ruled out before initiating steroid therapy. Urgent and appropriate treatment provides gratifying outcome. Always watch out for masquerades. Thank you all.